A 64-year-old woman has presented with complaints of breathless over the last 4 days. She describes a non-productive cough but denies any fevers or night sweats. Her medical history is significant for a recent diagnosis of right-side carcinoma of breast that was treated with a lumpectomy and a course of chemotherapy. Examination: the woman has reduced breath sounds on the right side of her chest, with dullness to percussion. Pulse oximetry applied to her finger shows a reading of 92% on room air. A chest X-ray is performed in the emergency department. Fresh lungs. What does the chest X-ray show? How would you investigate the underlying cause? What would be the best treatment to help this patient's symptoms?
The chest X-ray shows a large right-sided pleural effusion, as indicated by the opacification of the right lung field and loss of the costophrenic angle. This is often called a whiteout appearance. The mediastinum, heart, great vessels, trachea, and esophagus, has been pushed towards the left side of the chest. A sample of the fluid is needed. Pleural fluid can be sampled using a needle, thoracocentesis or pleural tap, and then analyzed. An ultrasound probe should be used to help identify exactly where the effusion is present, and then a needle can be safely inserted, ideally into the safe triangle area, a triangle bordered by the mid-axillary line, the lateral border of the pectoralis major muscle, a line superior to the horizontal level of the nipple, and an apex below the axilla. The fluid should be inspected grossly. Is it blood-stained or straw-colored? Does it appear viscous? These features will give clues to the underlying cause of the effusion. 4 types of fluid accumulate in the pleural space: blood, hemothorax, serous fluid, hydrothorax, chyle, chylothorax, and pus, empyema. Effusions can be classed as transudates or erudates, based on their levels of protein and lactate dehydrogenase, LDH. Transudate are caused by systemic conditions that alter the balance of pleural fluid production and resorption, such as heart failure, renal failure, and cirrhosis, and tend to have lower levels of protein and LDH. Exudates are caused by more local conditions, such as bacterial infection or malignancy, and tend to have higher protein and LDH levels. In this case, the patient has a history of breast cancer, so the fluid in her pleural space is to be a malignant effusion, and is likely to be an exudate. It may be that her breast has spread, so further tests will be needed to identify whether this is the case. With smaller effusions, a thoracocentesis may remove enough fluid to improve symptoms, but in a case like this, where there is a large volume of fluid, a chest drain should be inserted. Pleural effusions can recur, particularly malignant ones. Patients who develop malignant effusions despite optimal treatment of the malignancy may be referred for a pleurodesis. This involves inducing scarring of the pleura, either chemically or surgically, so that they adhere together to prevent fluid reaccumulating.